Have a seat again. Dr. McWilliams is going to sort of bring everything back together for us on Medicare, Medicaid, and how everything is integrated at this point. So without further ado, Dr. McWilliams.
Okay, now we're going to talk about a program that everybody is going to be a part of as either a provider or a consumer, or it's going to be your mama, or it's going to be your wife's or your daddy's mama. But this is something that we need to have a fair amount of knowledge about. Now, I'm going to show you some numbers here in just a minute that you're going to understand. So, anybody got an idea as to who these people are? Okay, LBJ's one of them. Yeah, you can tell that's Lady Bird. You can see her nose. So this is President Johnson. That's his wife, Lady Bird. You know who that is? That was the vice president at the time, Hubert H. Humphrey from Minnesota. That's his wife, Muriel. You know who that gentleman is? He was a president. That's Harry Truman. That's exactly right. This is, and we'll get to this in just a minute, but this is a historical picture of when the legislation was signed that created Medicare and Medicaid in 1965. It's in Independence, Missouri. We'll tell you the significance in just a minute. So we're going to talk about Medicare. You heard us talk about Medicaid. Not everybody loves these programs. A lot of physicians don't want to be a part of these programs. Now, I hope you choose to participate in Medicare because I'm getting ready to be there. But that's still a choice that providers get to make. You don't have to participate in Medicare. You don't have to participate in Medicaid. And indeed, this is from May of this year, 36% of physicians, this is a national number, 36% of physicians aren't accepting new Medicaid, and 26 said, you know what, I'm seeing all I want. I don't want to see any more. Medicare, 17% of physicians said, I'm not going to take any new Medicare, and 10% said, I'm not taking any Medicare whatsoever. So these are voluntary programs, but I think you're going to want to really strongly consider being a part of them as they move forward. The cost of health care, we've talked about it for a very long time. Yes, it's gotten a lot of attention, really starting back slightly before the election in 2008, when McCain and Obama had a lot of their discussion. But this is an article from the New York Times, it's 1930, and it puts the family health bill at $250 a year. So the president had convened a commission that said, we got to figure out how we're going to deal with the rising cost of health care. And it says it's the average family, and the average family at that time was 5 individuals. So in 1930, there were 5 of us in every family. We spent $5 a week on average for being in the hospital, for getting our medicines, for going to the doctor, for going to the dentist. This included that. They took 2 cities to do the study. They took Philadelphia and they took Detroit. And they took those 2 because they thought that they were the most representative of who's in the United States. Philadelphia didn't have many immigrants. Detroit had a lot of immigrants. There's a number of reasons that they did this, but they come through, and I think what's interesting is that the general task of the committee as outlined at the time it began in 1928 is to answer the question of how the increasingly complex facilities of modern medicine can be afforded by the average family. So we've been looking at this for a very long time. So $250 a year, 1930. Now, this came out in the AMA News just a couple of months ago. Annual health care spending now for an average family is $20,000. And yes, $20,000 today is a lot. The gap between $250 and $20,000 is not inflation adjusted. I'm sure you'd have to take that $250 and multiply it probably by at least 10. but there's still a very big gap. We've been talking about this for a long time. How are we going to afford health care? This is something Fidelity every year puts out a study, and they try to figure out, okay, so you're older, you're retired, you're on, quote, easy street, but how much is your health care going to cost? Well, what they say is that a retired couple, if you retire this year and you've got Medicare and you've done all the things you're supposed to, you're still going to have to figure out how to come up with $250,000 to pay your health care expenses as you go through life. And I started collecting this data 5 or 6 years ago, and it's gone up every single year. There are people who have questions about the methodology, but this is the assumption, is that, and I'm 64, so I'm going to be retiring sometime in the near future. So my wife and I got to figure out where's that $250,000 that we're going to need to take care of our health care expenses as we go forward. So who's in Medicare? Right now we got 49 million people in the United States who are in Medicare. We have a population of probably about 310 million in the U.S., and there's 49 million in Medicare. Starting in January of last year, the baby boomers hit us. I'm a baby boomer. I see perhaps a couple of other baby boomers in here. There are 10,000 individuals every single day who are moving into Medicare. That's a swamp that's coming. It's already started, and that's going to happen for 20 years. I went back, you've probably seen these little booklets you can pick up at grocery stores and filling stations, and it says, so you were born in a certain year, and you open it up and it tells you, what was the popular movie and the song that was popular and what was happening. And I was born in 1948. So I pull up mine and it says we're struggling to figure out how we're going to take care of the fact that we have a new baby born in the United States every 8 seconds. And you calculate that out, and you know what? That's about 10,000 a day. And that's how many people are moving into Medicare right now. And it's going to happen for the next 20 years. This is something from the Kaiser Family Foundation. I think it's very instructive. 1966, we had $19 million. We had 19 million people in Medicare, and that's when Medicare started. You can track that through, and now we're up to 48.5 million. Of this, these are the people who are 65, the blue line. These who are up here in the orange, as it says, they're non-elderly disabled. So we've gone from the inception when we had 19 million in Medicare. Last year we had almost 49 million, and we're going to add about 3 million a year to that for a very long time. Now, certainly some of these individuals are going to die off, but the net's still going to be close to 3 million a year. This is where Medicare population lives. Texas, 12% of the people who live in Texas have Medicare. We always talk about Florida. People retire, they move to Florida. That's where all the aged live. There's 18% of them. But West Virginia, 21% of the people in West Virginia, 20% of the people in Maine have Medicare. The state that has the least is Alaska. But you can see that just about everybody, and the national average is 15%, you can see where the older people are living. That's the darker blue ones. So we went over this slide earlier. So a while ago, how much did we say healthcare costs in the United States? $2.6 trillion. And remember, that was the 8,000. It's also almost 18% of our gross domestic product. And we went over this, how our numbers have gone up from 1970. So now, these are very huge numbers. That's why everybody pays a lot of attention to it. But from a Medicare standpoint, we started looking at this a long time ago. We started looking at this pretty soon after Medicare got enacted. Oh my goodness, how are we going to pay for what we just created? So the federal budget has several parts to it. This is the mandated part. This is the part that has to be paid. The mandated part of the federal budget is $2.3 trillion, and of that, $500 billion goes for Medicare, $280 goes for Medicaid. So that's a little bit over $800 billion. About a third of our mandated federal budget goes for health care in the form of either Medicare or Medicaid. Now, when people talk about Medicare going belly up, there's 4 parts to Medicare. They're talking about Part A. They're not talking about B, C, or D. They're talking about Part A going belly up. And Part A is what pays for you when you go to the hospital. So Part A, 57% of the cost of Part A comes from people when they pay their Medicare taxes. And if you work, part of what you make gets taxed. Part goes, and we'll talk about this in just a minute, part of it goes to Social Security. So you look at your pay stub the next time you get it, and there's a pay stub on there. I got mine with me, and it shows how much tax I pay every single time for Medicare and how much I pay for Social Security. We're going to talk about those two programs together because they are linked. But 57% of the cost of Medicare, of the revenue to support it comes from taxes and from premiums and from deductibles, things like that. 43% comes from the general revenue. And what's happening is, because the cost is going up so much, there's not enough general revenue to keep supporting it. And so you hear these projections that, oh my goodness, Medicare is going to go belly up in 2012, and then they redo it and it's going to go belly up in 2014 or 2020. The number always moves out, but that's a constant conversation we have, is when is Medicare going to go bankrupt, belly up? And they're talking about Medicare Part A. If you look at the total federal budget, not just the mandated, but the whole thing, it turns out to not be that 2.3 trillion, but 3.6 trillion. And Medicare and Medicaid make up roughly a quarter of the total federal budget every single year. That's a lot of money. We're spending more on Medicare and Medicaid put together than we are on defense. That's an awful lot of money. So let's step back. It's 1930, and what we find in 1930 is that medical care, the cost of medical care, was probably about 3% of our disposable income. So I've been paid, and remember, we already had income taxes in 1930. So that's already come about. So now we're talking about disposable income. So about 3% of the dollars that I had left after I paid everything was going to health care. And this is when that study was done that I showed you earlier. How are we going to take care of this? Because there was a recognition that, this is going to get more. And you can see over a period of time that has gone up, and when this slide was created, it was 16.6%. As we talked about earlier, our gross domestic product, we're now spending almost 18%. But the cost of health care in relation to everything else has gone up. Our cost for food used to consume up almost 25%, went up to 30% of our disposable income. That's now come down, and it's about 13%. Housing, about 14%. I have no idea why they put clothing and shoes on here, but clothing and shoes have gone down. We only spend about 4%. I think my wife probably bumps that up a little bit. So, as a nation, we're going through a terrible depression. There's people laid off. They got nothing. All of you have seen the pictures. You know how horrible it was. And so we have the Social Security Act of 1935. Oh my goodness, what are we going to do? How are we as a nation going to step forth and help those around us? Because before this, certainly there were groups, there were communities, but there was nothing organized to provide any sort of assistance. So we create what's called an old age reserve account. There is hereby created an account in the Treasury, old age reserve account, and it's going to start with the fiscal year that ends June the 30th of 1937. Medicare is an outgrowth of Social Security, and that's why we're talking about Social Security. There's going to be a benefit paid to people on the date that they attain the age, that should say 65 instead of 60 give, but as the age, and at that point in time, what we did was we looked at wages that somebody made up to about $3,000. That'd be a lot more money in today's benefits, but that's the way the legislation was written, was that you would be taxed actually on your income up to $3,000. If you died before you reached age 65, some of the money would come back to your estate. It still happens. It's not exactly the same way. My father-in-law died before he reached age 65. My wife had a younger sister, and so her mother got some money to help raise that child until she was, I think, 18. And then the definitions were a qualified individual, and actually you had to be working. Farmers didn't get credit for this. If you worked for the government, you didn't get credit for this. But under no, well, based on the amount of income that was paid to them. Up here, I should have said, the most that anybody could get from Social Security was $85 a month. That's when all this was started in 1935. So now we've got Social Security that provides some meager, but it does provide some assistance to individuals if they've been working. But as time goes through, we look and we realize, you know what, there's a lot of older people who really don't have very much. It's great that we've got Social Security, but what are they going bankrupt for? What makes them totally destitute? Well, it's health care. And so in 1945, Harry Truman proposes to Congress some sort of national health insurance, and Congress votes it down. It first got a lot of support, and at that point in time, health care wasn't considered to be any responsibility of the feds. It was supposed to be a responsibility of the states. And it was in the state of Wisconsin that most of this got started. A lot of states said that they thought that they would do something, but as World War II came about, priorities got shifted, this backed off. In 1945, Harry Truman says, I think we need something. He proposes it to Congress. The Pharmaceutical Manufacturers Association, the AMA, Chamber of Commerce, a number of organizations said we don't want that. It didn't happen. So for 20 years we talk about doing something, but we never do it. And it wasn't until 1965 when Lyndon Johnson was elected president. He defeated Barry Goldwater. It was a swamp. I mean, he had after the election, he had two-thirds of the senators were Democrat, probably at least two-thirds of the House of Representatives were Democrats. Johnson came in and he had what he called a great society. There were a number of things that happened under Lyndon Johnson. We had the end of segregation. We had Medicare. There were a number of things. But this is Public Law 8997. That means that it was the 89th Congress and it was the 97th bill that they put together. So this is the actual bill that creates Medicare. And if you notice down here, it says signed at Independence, Missouri, July the 30th, 1965. The reason that this was signed in Independence, Missouri was that Lyndon Johnson wanted to recognize the contribution that Harry Truman made. So he flies to Independence, Missouri. He could have signed this in D.C. He flies to Independence, Missouri. He sits down and he signs it, and he signs it with Harry Truman. And he turns around and Harry Truman becomes Medicare recipient number 1. His wife, Bess Truman, becomes Medicare recipient number 2. So those are the very first Medicare recipients, is Harry Truman and his wife, Bess. Now, remember that, and I hear a lot of people talk and they get confused about Medicare and Medicaid. Remember that Medicare is 100% federal. Medicaid is a partnership, and each state can handle Medicaid like they want to. Medicaid in Texas is different than Medicaid in Kentucky, different than Medicaid in Missouri. You've got different rules, you've got different regulations, you've got different populations who are covered. Medicaid in the state of Texas is about 18 different programs. We lump it under one title, Medicaid. But Medicaid in the state of Texas, 60% of the dollars come from the feds, and the state puts up 40%, whereas Medicare is 100% from the feds. So we've got Medicare that comes out of the Social Security program. At the current time, we have 163 million people who are paying into Social Security. And the income that you make is taxed, but there's a cap on that income of $110,000. So the first $110,000 that anybody in the United States makes, there's a tax that comes on there. It's 10.4% that pays for Social Security. Now that cap is going to go up to $113,000 next year, and there are, by the best estimates, there are at least 10 million people in the United States who are making this amount of money. You can start receiving Social Security when you're 62. You can go on, there's an estimator, you can go to Social Security on the website, and they'll tell you how much your benefit would be. You get a reduced amount if you start taking it at age 62. You got to start taking it by the time you're 70. In the United States, the average individual who receives Social Security gets $1,237. When you get your Social Security check, if you have Medicare, they deduct that before you ever get it. So you don't get that amount. You get your Medicare Part B premium taken out of that. These two programs, remember, are linked. And we'll go through the different parts of Medicare and the different costs for them in just a second. So that's Social Security. There's 163 million of us paying into it. Now, as we just said, there's a cap. So up to $110,000 gets taxed, and it gets taxed at 10.4%. If you work for yourself, you pay the whole 10.4. If you work for somebody else, you pay 4.2, and your employer pays 6.2. You still get to the 10.4%. And if you look on your check, there's going to be something on there it's going to be an old age tax, and it's 10.4%. So the first $10,000, it's going to be about $10,500 of taxes are paid. You're only going to see about $4,000 because your employer's paying the rest of it. But that's what's going into Social Security. For Medicare, there is no cap. You get taxed on Medicare as far up as it goes, and the tax is 2.9%. If you work for yourself, you pay the whole 2.9%. If you work for somebody else, it's split. They pay 1.45 and you pay 1.45. Now, Medicare as we know it today is not how Medicare was created. It continues to change. It continues to evolve. What we pay changes. The benefits we get changes. I just want to walk through some of the more significant changes. We talked earlier in 1945, it's Harry Truman who sends the message and says, I think we need some sort of national health insurance. In 1965, Lyndon Johnson actually gets it done. Harry Truman becomes the first enrollee, and at that time the Part B premium was $3 a month. Medicare Part A pays for you going to the hospital. If you have worked 40 quarters and you've had your taxes paid, the assumption is that your Medicare Part A is paid for. So you don't have to pay anymore to have Medicare Part A. You've done that. You still have to pay when you use it, and we'll talk about that here in just a minute. But you're in, if you go down and you fill out the paperwork, you're enrolled in Medicare Part A. Medicare Part B is what you as physicians need to know about, because that's how you get paid. And Medicare Part B is voluntary. You do not have to sign up for Medicare Part B. But the first premium was $3 a month, and everybody paid the same. If you made $1 million, if you made $1,000, everybody paid the same $3 a month. So it was really just for the old age. But in 1972, the decision was made that we're going to expand who's in Medicare, and we're going to bring in people who have end-stage renal disease. We never paid for dialysis before 1972. When I went to medical school here, Dr. Forland, some of you may know Marv Forland, he's a retired nephrologist. We had a committee, and we sat down to decide who was going to go on dialysis. And if somebody had a condition that we thought was a progressive, deteriorating condition, they didn't go on dialysis. You know, the first diagnosis that kicked people off the list was diabetes. So if you had diabetes, you did not go on dialysis. That's who 99% of our people are that are on dialysis right now, probably have some history of diabetes. But before 1972, people who had a progressive disorder, they didn't go on dialysis. Medicare certainly didn't pay for it. But in 72, we started paying for people who were disabled, if they were under the age of 65, and we included end-stage renal disease. In 1983, we went from a reasonable cost to a prospective payment system. Before 1983, if you went to the hospital and you had lots of stuff done, what the hospital did was they turned around and they submitted to Medicare a list of all the different costs that they incurred. And Medicare turned around and they paid them cost plus 6%. It's a great deal. You know, if my costs are $1 million, I got 6% coming. If my costs were $2 million, I got 6%. So if I can make the cost more, I got more money coming down. And the government figured that out, and they said, we can't keep paying cost plus. So they went to a prospective payment system. We know that as DRGs, diagnosis-related grouping. There were many, many hospitals who went out of business because they couldn't understand the rules. I can remember picking up newspapers all the time. Well, there's another hospital that just closed. Because what a DRG does, a DRG says, you know what? We've looked at this all over the nation. We understand about what the cost should be if you come into the hospital and you've got pneumonia. And so that's what we're going to pay. And we don't care if you order 20 x-rays or you order 1 x-ray. We don't care if you give them the most expensive antibiotic or the least expensive antibiotic. This is how much we're going to give. Now, Medicare also looked to say we want to make sure the quality's there. We don't want people just cutting back. But there were lots and lots of hospitals that went out of business when this change took place. 1988, we started paying for mammography. We never paid for it by Medicare before then. 1989, started paying for pap smears. 1992, physician services got based on a fee schedule. Before 92, a physician could submit a fee. Didn't always get paid, but you got paid pretty close to whatever you submitted. So you kept thinking, well, gee, why should I keep my costs down if Bob down the road is charging twice as much and getting paid a lot more than I am? Medicare caught on to that, and they said, we're going to set up a fee schedule. So that started in 1992, and we'll look at the fee schedule in just a minute. That's how you get paid for, and I will tell you, almost every managed care plan uses Medicare as the basis of how much they pay you. So they may not pay you Medicare, but they're going to pay you a percentage of Medicare. 2005, we started this Welcome to Medicare physical. We said, you know what? It makes sense to control the cost. If you come into Medicare, you come in and you meet your physician, and let's do a physical, and let's start taking care of you up front. In 2006, we started Medicare Part D. That pays for the outpatient drugs that were never paid for before, except in the case of end-stage renal disease. You could get that paid for. And in 2010, and this is through the Affordable Care Act, if something is the U.S. Preventative Services Task Force recommendation A or B, then that's going to be covered. So you can go in and you can get those services. There's no copay, there's no deductible on that. There's a push to let's make sure that we're doing those things for the individuals who need them. So let's talk about how much Medicare costs me or you as an individual. We talked earlier that if you've got Medicare A, and that's the part that pays for the hospital, most people don't have to pay it because they've already paid their medical tax, their Medicare taxes while they were working. But if you haven't, your premium is going to be $451 a month. If you choose to delay, if you turn 65 and you choose not to enroll in Medicare Part A, because gosh, that's a lot of money. I don't think I want to pay $5,000 a year. I'll wait until I need it. And so 2 years later, you decide, you know what, I think I'm going to need Medicare Part A. You could get it, but you have a penalty that you have to pay. Your premium is going to be 10% more than that per year. So it's going to be 20% more than the $451, and you have to pay that for a certain amount of time. And again, that goes back to the concept we talked about earlier. The way that insurance works is everybody's got to be paying in so that when I need the service, the dollars are there. And if we wait and we only pay when we need the service, then the cost goes way up. So Medicare wants you to enroll when you should. They want you to make some payments so that they have enough money to cover those people who need services. So that's Medicare Part A. Medicare Part B, for a long time, everybody paid the same Medicare premium. In the year 2007, that's not very long ago, in the year 2007, we started indexing what your Medicare Part B premium was. This is voluntary. We indexed it to what your income was. Medicare Part B, again, pays for you as the physician. It pays for outpatient laboratory and outpatient radiology, a few things like that. But now, if you're a couple and your income is below $170,000, your Part B premium is roughly $100. So I've got Part B, my wife's got Part B, our income is below $170,000. Our Medicare Part B premiums together are going to be $200. If we want the drug benefit, the Medicare Part D, it's going to be an additional $30 for each one of us. So it's going to be $260 a month for my wife and I to have Medicare Part A, pay for the hospital, Medicare Part B, pay the doctor, and Medicare Part D to help us with our outpatient drugs. If we're fortunate enough and our income is higher, then we're going to start paying more. And right now, if your income is above $428,000 as a couple, your monthly premium would be $319, and your Part D premium would be almost $100. So it's indexed, and we no longer all pay the same amount, but it's indexed. And they'll use the most recent tax returns. They'll find it. You don't have to submit it. They'll find the information for you. They'll figure out what your premium ought to be. Again, Part B is the same thing. If you decide that you don't want to enroll, then you have for every year that you delay enrolling in Part B, you have a 10% penalty, and that stays with you for the rest of your life. So if it's supposed to be $100 and you wait 3 years, you're always going to pay 30% more than anybody else does for your Part B. So again, they want you to enroll in Part A and Part B when it's time. So you've got Part A, you've got Part B, you've got Part D, but now you got to go to the hospital. Well, you have to pay a deductible when you've got Part A. So you have to come up with the first $1,156. And then Medicare will step in and Medicare will help after that. But you have to come up with that. You've got Part B. And by the way, these are every single year. These are on yearly basis. So when you go in January of 2013, you got to pay this. When you go in January of 2014, you got to pay it all over again. So these are on a yearly basis. You're going to go see the physician. You have to come up with the first $140. Now, I've already seen Dr. Joe down the street. I already paid my $140, but it's the first time that you've seen him. So you have to know, have I or have I not paid my deductible already this year? And there are ways that you can work through that. But as an individual, regardless of where I'm receiving my care, I've got to come up with $140 before Medicare Part B kicks in. I've got to come up with the $1156 for Part A, and then Part D that helps me with my drugs. I've got to come up with that. So Medicare Part A, paid in the hospital. It covers me when I turn age 65, and it starts the first day of the month that I turn 65. About 10 years ago, there was a recognition that we needed to pay for an additional group, and that was individuals with Lou Gehrig's disease, ALS. And so if you're diagnosed with ALS, your Medicare starts immediately. If you're under the age of 65, you have to be receiving some disability benefits for 24 months. Once you've received those for 24 months, then you'll qualify for Medicare. So somebody comes in, they're disabled, they start getting payments, you know they need health care, it's still their responsibility until 24 months have passed. We talked a minute ago about the Part A deductible being $1,156. That covers you. There's no other cost that you have as a patient in the hospital through day 60. But after day 60, you've got a cost of $289 a year. There's some other limits that go up. There's lifetime limits, but this is going to take care of the vast majority of your patients. And this starts over every year. So I would get 60 days this year at no cost. I could get 60 days next year at no cost. I could get 60 days the year after that. From day 61 through 90, I've got to come up with that additional money if I want to stay in the hospital. I can remember in a small town that I lived in, there was a lady who had so much money she couldn't count it. And she chose, instead of going to a nursing home, they just gave her a room at the end of the hall. And she just paid her money and stayed in the hospital until she died. So what does Medicare Part A cover? And we talked about this a minute ago. Most of it's hospital care, some skilled nursing, hospice, and some home health services. But really and truly, the biggest part is being in the hospital. What does Part B cover? The biggest part of Part B is seeing the physician, taking care of that, but it also pays for ambulance services, it pays for radiology, outpatient, pays for outpatient laboratory services. The Part D, you got to come up with that initial amount of money. Part D under healthcare reform is supposed to change. Right now, there's a graded scale. You pay a certain amount, and then you go in and you and the government pay together a portion, and then you reach something that's called the donut hole, and you pay for all of that yourself, and then you pass the donut hole, and the government pays for almost all of it, and then the year runs out, and you start all over again the next year. I will tell you, as a physician, when we knew that Medicare Part D was coming about, I sat down with a PharmD who worked with me, And we spent a couple of months trying to figure it out. It's very confusing. There's over 1,000 Part D programs in the United States. You have to figure out which one of those Part D programs you want to be enrolled in, which means you have to know the medications you're on. You have to know whether that program covers the medications that you're on. What's the cost of them? Are there any hidden links? It is very confusing. And I believe there are many individuals who are mentally challenged when it comes to really trying to make a good decision on Part D. It is a very confusing program. It's better than what we had before because we had nothing, but it is still a very confusing program.
Can you go back a couple slides up? Medicare Part A. When you're looking at the Medicare Part A donut hole at 61 to 90 days, if you manage to go 60 days in the hospital and then go to a nursing home or get home health care or something like that, is that still covered in that donut hole, or is that still the responsibility?
Well, now Medicare is probably only going to pay for skilled nursing. Medicare is not going to pay for you going to a regular nursing
So
home.
if you manage to get into a skilled nursing facility, does that?
Yeah, that's separate.
That's separate, so you managed to avoid that, so 60 days and out. So on the next one, the Part B, one of the things that we found out through an article in AARP actually, is that when you put a patient on observation status, it's no longer Medicare Part A, it's Medicare Part B. And that then gets covered differently because the medications are billed through actually Medicare Part B or given as an expense to the patient. So when our hospitals are encouraging us to put patients on observation, it's taking away Medicare Part A coverage and putting the patients into Medicare Part B coverage, which is completely different, and a lot of them don't even understand that.
Yeah, the point he's bringing up is a really important point, and I've seen it written up in the New York Times a couple of times. Patients are saying, I don't understand, doc. I went to the hospital. I was in there for 36, 48 hours. I thought I was admitted to the hospital. They brought me trays. I had a nurse that came and checked on me. They took my vital signs. They sent me home. I thought I was admitted. And here's all this stuff that I'm supposed to pay for this. Under Part A, I would have paid the $1,156 and then I'd been out of there. I don't care how many things they did. Under Part B, every time they did an x-ray, every time they brought me anything, I got to pay that. And under Part B, after you pay your deductible, then you're paying 20% of the Medicare fee schedule. And so the bill is a lot more. So patients who are placed in observation, if they've got Medicare, that's a big deal to them. You just raise their cost of care a bunch.
And then what everybody's asking is, what is Medicare Part C, since you're skipping over?
Okay. Medicare Part C is the HMO option, the managed care option. So A is the hospital, B is the doctor, D is the drugs, and C is what we used to call Medicare Plus Choice, Medicare Advantage. It's the managed care program where you enroll, and it really is it's a Medicare HMO. You get the same benefits that you would under A and B. Plus, most of the time, you get your Medicare Part D covered also. And then there's some other things that are covered. Part of the discussion that's taking place is that those programs that produce or provide that Medicare Part C, that Medicare Advantage plan, they get paid more than the cost of care. And the federal government is looking at that and saying, we can't afford to keep doing this. Right now, the Medicare Advantage plans are very beneficial. If you're a physician and you're enrolled in one of them, you have a chance to make a fair amount of money. But the federal government is looking at reducing, and they are reducing, the payments that are going to the Medicare Advantage plans. But it's the Medicare HMO option.
So the biggest difference between that is that you have to stay within a network of providers as opposed to straight Medicare.
If you want to get it paid for, yes, that's exactly right. So, and I'll try to go to this here in just a minute. Medicare's got a really good website. And I think it would behoove you to go to the Medicare website because they collect an awful lot of information. They're beginning to, and remember, we got 10,000 people every single day who are moving into Medicare. And they're people who are going to learn how to use the computer if they don't already know how to do this. You can go on and you can figure out, so what's a good hospital? Why does one hospital better than another hospital? And the focus has been on hospitals. They're now collecting the data on physicians. And so there's going to, right now there's something called Hospital Compare, when you go in and you look, they've got data on physicians, and they'll compare you with your peers, and your patients will be able to pull that information up. Already they can see which physicians have submitted quality indicators to Medicare because there was a benefit, a financial benefit to doing that, and which have chosen not to, or if they did, they haven't reported it. But I'm just saying, as a younger physician, I would really want to know what my profile looks like under Medicare. So here's one of the resources. In fact, this is a whole list of resources, and I'm just going to, just for a minute, I'm just going to slip down to, how do I move this pointer to get to the Medicare point?
Use that. Crazy. I don't know why it's not working. I think, there it is, right here.
Okay.
It should be up. Let's make sure I can, let's pull it
Yeah.
right over somewhere.
So here's what you get when you go to the, and I may keep Dr. Bosler up here with me as we go through this. So here's what you get when you go and you look at Medicare. You can get your questions answered. You know, how much do things cost? How do I appeal something? What's out there for me? But under what does Medicare cost? Gosh, I'm interested in finding a doctor or a hospital or a facility, so I can come down and I can click this and
That's good. Make it smaller here.
I will tell you one thing that I find very interesting. I live in Fair Oaks. My zip code is 78015. When I type in 78015, it incorrectly lists me as living in Bernie. So then when I live in Bernie, I can only pull up providers within 25 miles. And when I tried to pull up the urology group here, you're not within 25 miles of Bernie. So anybody, my zip code and farther up, when I use Medicare.gov to find out who I want to go see, I don't get the providers here. So I don't know who needs to be working with somebody. Now I could go in and type in San Antonio and I would get the people here. But when this asks you, you know, enter a location, it's not going to happen. So if I was to come right here, I don't even know, what's the zip code here?
78229.
78229. Okay. And
You click down to physician, you're going to scroll down. The other way. There you go. Just hit physician. Click
okay,
on the
and I want
physician
to do physician.
button. And then hit search.
And then under physician, I want to do specialty.
Right.
And I'll tell you that urology is the very bottom one.
Now you should be able to.
Oh, yeah. So what this says is that within 15 miles of this zip code, there's 109 urologists. It'll show you.
Dippen's a lot farther away than Rosansky's here.
If you go in, it'll tell you where you went to medical school under the profile. Now, it doesn't have that any of you participated in the Physician Quality Reporting Initiative. I don't know if you did or not, but some of your peers are listed as having been a part of this. It would show up right over in this area right here. So at this point in time, it just says, you know, where, and actually this doesn't even say where you went, where you graduated. The amount of information is different for individuals, but I would want to be looking at this periodically to make sure that it's correct, and I'd want to be doing everything I can to look good on these sheets. If any of you get Consumer Reports, you know that for the last couple of years, Consumer Reports has rated groups in the Northeast, and you get about a 15 or a 20-page document that says, you know what, this is a group you probably don't want to go to. This is a group you do want to go to. They've got stars in there, and I'm just telling you, right now the focus is on hospitals, but it's coming to physicians very, very quickly. Okay, so we'll go to.
There you
If we were to go to Trailblazer or Novitas, I could show you how you can look up how much you get paid for something. When Medicare was created, everybody was afraid that the government shouldn't be running all this. So what the government did was they said, we're going to go to private companies to administer Medicare. And in Texas, for a long time, we've been using Trailblazer. Trailblazer for Part A has already gone away. We no longer use them. We now use this Novitas. For Part B, we use Trailblazer, and that's for you as physicians. But that's going to change in just a couple of weeks. And we as physicians, when we start looking, we're going to go to Novitas. You go in to their website, you accept an agreement, you go in and you can pull down, this is Texas, this is 2012, and Medicare is set up to, and I'm going to go on to the next slide here, because I think it'll explain it. You get paid based off of a calculation. And you don't need to know the calculation, but just know it's very complex. And you get paid differently depending on where you practice. There's something called the Geographical Practice Cost Index, the GPCI. I will tell you, a couple of years ago, there was a huge discrepancy, even in the state of Texas, for what you did. That physicians in Dallas got paid a lot more than physicians in San Antonio. Physicians in Houston got paid a lot more. When all this was set up a number of years ago, physicians, in my opinion, and other communities were a little bit smarter. They realized they needed to create their own areas, and so they did, and they got paid more. San Antonio sat back, and we got lumped in what's called the rest of Texas. So all these other areas, they've got their own reimbursement, and San Antonio is lumped under, and the rest of Texas. So, and this is an example I use when I do a primary care talk. But the most common code we see is 99213. And if you were in Harris County, last year you got paid $69.41. In San Antonio, you got paid $66.90. If I'd gone back a couple of years ago, this would have been even more. One of the things that's supposed to happen under healthcare reform is that this narrows down. But if I'm a typical family physician, by just practicing in Harris County, seeing the same number of people I do right now, I could have made an extra $10,000. A couple of years ago, that would have been $30,000 or $40,000. And that does drive where some people practice, because they look at this stuff and they say, wow, you know, taking out a kidney is the same whether I do it in Dallas or Houston or San Antonio. If I'm going to be there for a long time, why don't I go someplace that pays more? Even though the patient's still got the same Medicare product. If you go and you look at the fee schedule, this is what you see, line after line, column after column. These are all CPT codes. And when you take out a kidney or you do something, you don't tell somebody you took out a kidney. You write down a CPT code, a 5-digit number, which tells a computer somewhere else how much they need to pay you based on where you practice and a number of other things. But this is just one page. We blew up part of it so that you could take a look. Here are a number of CPT codes that urologists would use, somewhere in the 5,000 range. You see an N and an F. You get paid differently whether you are providing that service in an office that you own, you're paying the people, you're paying the light bill, or whether somebody else has that cost. And so you're just getting paid the professional component of it. It doesn't matter what you charge. If they have Medicare and you have agreed to participate in Medicare, that's how much money is going to be paid for that service, $1,161.93. So the patient has Medicare Part B. They've had to pay their premiums. They've been doing that. But then now they've also got to pay that deductible that we talked about. After they pay that deductible, this cost gets split up. The federal government will pay 80% of that, and the patient is expected to pay 20% of that. And that goes all the way down from top to bottom. And so when Dr. Bosler was talking a minute ago about the patient in the hospital being under observation, every single thing that happened to them, there's a CPT code, and there's an amount that gets listed, and the patient is responsible for 20% of that. And that adds up. That adds up in a hurry. We talked a minute ago about PQRI, that physician quality reporting incentive. The government wanted physicians, and they still want physicians, to report how they're doing on certain metrics. And so whether you do it great or terrible, if you just reported, you got paid a bonus. In 2011, they took all of your Medicare payments and they added 1% to it. In 2012, 13, and 14, they'll take all the Medicare payments and they'll add 0.5% to it. Now, starting in 2015, if you don't do it, they're going to start penalizing you. So there's been a reward for reporting, but starting in 2015, if you don't submit your quality indicators, you're going to get dinged. Medicare wants primary care physicians to step forward. They want a lot more care delivered at the primary level. So what they've done is, starting last year, if you're board certified, you provide services in family, internal, geriatric, or pediatric medicine, you can get paid a 10% bonus. So instead of getting $65, I'm going to get $65 plus $6.50. And so it's a stimulus to try to drive people into primary care. Also, we know that there's a shortage of general surgeons, especially in what we call underserved areas. So if general surgeons provide major surgical procedures in these health professional shortage areas, they get an extra 10%. There's nothing on here about specialty other than surgery. And that's the way that Medicare and others are looking as they move forward. So Medicare's got this big bet on primary care. They're hoping that by having more people spend more of their time with the primary care physicians, they can keep the cost down. I assure you this is all about cost. So those are the services that are available, but here's what they're looking at. Boosting primary care pay could lower net spending by almost 2%. Doesn't sound like much, but if you're spending $800 billion on healthcare and you can reduce that by 2% a year, that's a very big number. Certainly there are some physicians who have said, you know what, I've had it. This is too much. I can't keep up with all this. I will tell you, when I went into practice, I don't think it was nearly as complicated as it is today. Many physicians went out and practiced on their own. You didn't have to know all these rules and regulations and report all this stuff, but it's become so complicated that almost all physicians now that I know, when they leave, they don't go out by themselves. They join a group. They do something where they're employed so that others can take care of that. But there are some physicians who do concierge medicine. They just don't take insurance. If you've got the cash, come and see me. I'll take care of you. If you don't have the cash, you need to go somewhere else. I'm not sure that that's a long-term solution. I think that works for a very small group of people and physicians, but it is out there. Medicare Cost Control Board. There is a board that's been set up to help us look at what do things cost. I've heard it called a death panel. I'm not sure it's really a death panel. I think it's actually, in my opinion, it's a pretty good idea. We've got physicians who are supposed to sit and make some decisions. What makes sense and what doesn't? Is there a better way to do something? And as I talked about earlier, I don't want an accountant making that decision. I think it makes sense for the physicians to make those decisions. Now, certainly somebody's got to ask themselves, when there's a medication and it's going to cost $100,000 and it's probably going to add 6 months to somebody's life, as a society, is that the best way to spend that $100,000? I don't know. Now, if I'm the patient, I'm going to say, yeah, bring it on, because I want that $100,000, I want those 6 months. But as a society, I think somebody's got to really make that decision. And I think the right people, in my mind, to do that are the healthcare providers. So I wouldn't call these death panels, but I do think that that's what they're going to be looking at, is what makes sense, what should we be doing. That's pretty much it. I'll be happy to take any questions. Again, you got 10,000 people every single day who are enrolling in Medicare as we move forward. That's going to be out there for a very, very long time. I hope you decide that you want to participate in Medicare, because I'm going to need somebody to take care of me. Thank you. Yes, ma'am.
You know, here in San Antonio, I find it very hard to find at least subspecialists in the private practice who do continue to take new Medicare patients. And so what is your sense of the future with the Affordable Care Act, and will this get much worse?
You know, we struggle a lot with our CareLink population to get them some subspecialty care. But you'd be surprised at the number of calls that I get, and it's somebody who's got insurance, and they say, I can't get in to see a rheumatologist before next March. I can't find anybody in the community. Can you recommend somebody? I think it's going to get really, really tight. And I think at some point in time, this is just me. You know, we already have these health professional shortage areas, and if you have student loans, if you go practice in a health physician shortage area, you can get part of that loan repaid back, and you can, I think you can practice for, the last I looked, it's a very long time. You can practice like for 25 or 30 years, and you still get some loan repayment. If I was going to guess what's going to happen in the future, I would guess that there's going to be more programs that are going to provide some loan forgiveness if you'll step up and you'll see Medicare patients. And it won't just have to be in a health professional shortage area. It'll be others. There's not enough training that's taking place. There's not enough slots. There's not enough people out there. If you changed it today, it would take a long time to make any sort of an impact. I think that that's going to have to be the next step. We used to not have a designation of health professional shortage areas, and we used to not help pay loans off when people would go practice in there. But it was a recognition that we had populations that couldn't get health care, and how do we drive people to provide that health care? And so downtown, the medical center does not qualify, but downtown does. Our southeast clinic does. Our southwest clinic does. So we're able to recruit physicians to those areas, and they get their loan repaid. We have a cardiologist downtown who works for UT, but he's stationed downtown. He gets his loan repaid. We have a pulmonologist downtown. They get their loan repaid. So I see a lot more effort along that direction. Anything else? Thank you.
Thank you so much. That was wonderful.